Greetings and salutations, all my brothers and sisters. It's Dr. Ryan here again with our 12th overview video in algorithms and mnemonics in internal medicine. A big thank you to everybody who's been liking and sharing and subscribing to my channel. We have reached a whopping 1,000 subscribers. God bless you. And I pray that you are enjoying this content as much as I am enjoying bringing it to you. Alrighty, today we're talking about Hirsutism. Just a quick joke. You ever wondered why wigs are so competitive? Well, because they're always trying to get ahead. Okay, so here's our clinical case for today. What we have is Mrs. Bezoar. Oh dear, a 19-year-old white woman complains of worsening excessive hairiness and is worried that she will be mocked as she starts university. She notes increasingly noticeable hair wear on her upper lip, chin, and arms. She takes no medications, that's an important negative, and reports a history of irregular menses. Interesting. On examination, she has normal vital signs, and you note small to medium tufts of dark hair in the areas that she has mentioned, plus in the midline, above and below the umbilicus, along the inner thigh, and on the upper and lower back. Very specific distribution. All of the statements regarding her condition are true, except that A, further hormonal evaluation is likely necessary. B, she likely has elevated androgen levels. C, she meets the diagnostic criteria for hirsutism. D, the most common cause for her condition is congenital adrenal hyperplasia. Or E, this condition affects approximately 10% of women. Okay, first up, everybody, what really is hirsutism? It refers to the excessive growth of hair in women, but not just in any distribution. It is in the male pattern distribution due to excessive secretion of androgens. So hair growth occurs usually in the beard or chin or the mustache area, and also in on the breast, the chest, the axilla, abdominal, midline, pubic, and thigh area. Excuse me. Increased hair growth indicates excessive androgens. Now, these androgens can be either adrenal or ovarian in origin. And by and large, hirsutism, we can partition it into two groups: hirsutism without virilization and hirsutism with virilization. So the million-dollar question is, what is virilization, or what is the clinical evidence of virilization? Well, typically you have male pattern baldness, especially frontal baldness. You have a kind of like a male body habitus. We have other kind of secondary sexual characteristics that, pertain to a male, right? In terms of deepening of the voice, and other things can be clitomegaly, breast atrophy, male pattern pubic hair, greasy skin. What are the causes of hirsutism without virilization? So if we don't have these other stigmata that we spoke about, the deepening of the voice, the clitomegaly, etc., then the causes of hirsutism include idiopathic in most cases. It can be familial, drugs, and more drugs. So steroids, phenytoin, cyclosporin, androgens, minoxidil, progesterone are the usual culprits. Others include polycystic ovarian syndrome in a mild case, acromegaly, and our beloved porphyria cutanea tarda. What are the causes of hirsutism with virilization? So here you're thinking, are these excess androgens coming from the ovary or from the adrenals? Ovarian causes are severe cases of polycystic ovarian syndrome, as well as androgen secreting ovarian tumors. Adrenal causes include late onset congenital adrenal hyperplasia, Cushing's syndrome, adrenal carcinoma, and androgen secreting adrenal tumor. So here's some images courtesy of short cases in clinical medicine. God bless you guys. Here we can see hirsutism, right? So excessive hairiness, all right? Here is hirsutism in senility. We can see increased hair distribution in the beard and mustache area, and again, hirsutism here, facial hair. So, okay, if you have a patient who presents clinically with hirsutism, what is the important or significant history that you want to take? So first up, what was the age at the onset of the hirsutism? Generally, if the patient was younger and if it occurred at an early age, a common cause is our beloved polycystic ovarian syndrome. And what adds weight to this on the history is a history of amenorrhea, weight gain, or infertility. If elderly or middle-aged, you're thinking, okay, the hirsutism is most likely postmenopausal. What about a family history? Does it happen in other family members as well? right? And if you suspect Cushing syndrome, in that the patient not only has hirsutism but other phenotypical characteristics which portend to a diagnosis of Cushing's, for instance, a dorsal fat pad, so-called lemon-on-a-stick appearance, livid abdominal stria. The patient has osteoporosis, immunosuppression, hypertension, hyperglycemia, other stigmata of Cushing's. You want to take a history of a prolonged intake of steroids. So does the patient take exogenous steroids? What about weight gain? Important to take a drug history because many of these drugs are culprits which cause hirsutism, like is the patient on steroids or androgens or phenytoin or cyclosporin or minoxidil. What about a menstrual history? Amenorrhea adds weight to polycystic ovarian syndrome. How fast really is this hirsutism progressing? What's the rate of progression? Is there thinning of the scalp hair as well, which pertains to hyperandrogenism? As we know, a good history regarding hirsutism is essential. So if the onset is shortly after menarche, tumor is unlikely, right? If the onset is in childhood, there's a greater chance of an underlying disease process. If menses are regular, then it's most likely constitutional hirsutism rather than tumor or any other pathology. The greater the menstrual abnormality in that the menses are irregular or the cessation of menses, the more likely there is a serious disease afoot, whether it be ovarian or adrenal in pathophys. Rapid onset, prepubertal or late onset is highly suggestive of underlying disease, be it ovarian or adrenal. Increased libido and signs of virilization indicate increased androgen. Okay, so you took a history, you did the examination. How does one investigate hirsutism really? Thorough history, like we mentioned, history of drugs, family history, and then the cause may be by and large ovarian or adrenal. So you want to do an ultrasound of that abdomen and determine if there is an ovarian or an adrenal mass present. All right. If indeed this is ovarian in origin, the following hormonal panel should be done. You take the blood for testosterone, luteinizing hormone, follicle stimulating hormone, and prolactin. Right, so if the luteinizing hormone is high and the FSH, follicle stimulating hormone, is normal or high, that is the ratio of LH to FSH is about 2:3. That's suggestive but not diagnostic of polycystic ovarian syndrome. If the testo is high, which is more than twice normal, with a low LH and FSH, it's unlikely to be PCOS. It's likely to be idiopathic hirsutism. It's good to also do your sex hormone binding globulin, and this is usually high in cases of hirsutism. If the androgens are high but the testo is normal or low, that's also an indication of hyperandrogenism driving the hirsutism. Other tests one can do is a CT scan of the abdomen, MRI, and sometimes fine needle aspiration cytology and even laparoscopy can be done, right, of those ovaries. Now, if the hirsutism is due to an adrenal origin, right, and you're thinking, okay, if adrenal carcinoma or adenoma, it's good to do a urine 17 ketosteroid level, right, you can also use a dexamethasone suppression test, which may be done to check for failure of suppression if you're thinking about Cushing's. If you think that it's congenital adrenal hyperplasia, you want to do your 17-hydroxyprogesterone, and that's high, and also you have a high ACTH. Other tests that can be done are CT of the adrenals, MRI. You can even try a fine needle aspiration of the adrenals, and sometimes laparoscopy. This is another way to represent your investigations. So the first question is there a rapid onset of hirsutism? If no, then you proceed to take a history of drugs and family history, like we said. And if those are both negative, you're thinking this is non-neoplastic androgen secretion, and your options there diagnostically are polycystic ovarian syndrome, congenital adrenal hyperplasia, and idiopathic. However, if there is indeed a rapid onset of hirsutism, you have to be concerned that this is an ovarian or adrenal etiology. So you get your ultrasound done and get your other investigations like we discussed according to the size of the lesion, including CT, MRI, and laparoscopy of those ovaries or adrenals as necessary. How do we treat hirsutism? Well, firstly, we address the primary cause. What is causing it? If it's due to a drug, simply discontinue the drug. And also, local therapy includes plucking, bleaching, depilatory cream, shaving, electrolytes, epilation. You can also use topical eflornithine cream, which is applied locally for 6 months. It's also proven effective. And of course, systemic therapy is given in severe cases. So cyproterone acetate, which is essentially an anti-androgen at a dose of 50 to 100 milligrams daily for about 1 to 14 days of each cycle, right? And in women of childbearing age, contraception is essential because hypertrichosis has teratogenic potential, right? Estrogen is our other go-to drug in the formulation of an oral contraceptive pill. It's helpful in both idiopathic and polycystic ovarian syndrome, and it reduces free androgens. How? By increasing your sex hormone binding globulin. Metformin reduces the androgen level and may be given in treatment of hirsutism associated with insulin resistance. So it acts mainly on the metabolic arm, but may actually regulate your ovulation as well. Metformin also has additional cardiovascular benefits, right? Other anti-androgens like spironolactone or frutamide and finasteride have proven helpful as well. Okay, what is this thing called hypertrichosis? And what are the causes? Hypertrichosis refers to generalized hair growth in any sex which is non-androgenic. So the key word there is non-androgenic in origin. Causes are familial, can be sexual precocity, adrenal hyperplasia or neoplasm, could be a virilizing ovarian tumor, and drugs as usual like minoxidil, cyclosporin, androgen. All right. What are the causes of diminished body hair? Well, you're thinking liver cirrhosis, okay. Klinefelters, so that's one of the chromosomal causes, hypopituitarism, and bilateral testicular atrophy from any cause, right? Example, leprosy, mumps-orchitis, and so forth. So, guys, here we had our clinical case with a young Caucasian female who's noticed excessive hairiness in a male pattern distribution, right? Upper lip, chin, and arm. She has, on the history, there's no medications and there's irregular menses. She is vitally normal and she has hair as discussed. And the most common cause for her condition is indeed congenital adrenal hyperplasia. So an objective clinical assessment of hair distribution and quantity is central to evaluating any woman who presents with hirsutism. And this assessment permits the distinction between hirsutism and hypertrichosis, right? Because we said hirsutism is due to hyperandrogenism, right? As opposed to hypertrichosis, which is not. And this delineation provides a baseline reference point to gauge how we're going to respond to treatment. Now, a simple and commonly used method to grade hair growth is a modified scale of Ferriman and Galloway. Here, we're looking at each of 9 androgen-sensitive sites, which are graded from 0 to 4 in terms of the amount of hair they have. Scores above 8 suggest androgen-mediated hair growth, a finding that should be assessed further by hormonal evaluation. And these are the 9 typical areas where you expect hair growth in an androgenic distribution. So looking at the upper lip, and it's graded from 1 to 4 in terms of the amount of hair you have there. The same with the chin and the chest as depicted, the abdomen, the pelvis, upper arms, thigh, upper back, and lower back as well. Remember, a score of above 8 suggests androgen-mediated growth. Okay. Beloved, I just want to encourage you about wisdom this morning. The book of Proverbs, chapter 9, verses 9 to 10 says, "Instruct the wise, and they will be wiser still." All right? Teach the righteous, and they will simply add to their learning. Then the most beautiful part of this scripture for me is, how does one acquire wisdom? By fearing the Lord. The fear of the Lord is the beginning of wisdom. And knowledge of the Holy One is understanding. For through wisdom your days will be many, and years will be added to your life. If you are wise, your wisdom will reward you. If you are a mocker, you alone will suffer. So do you desire wisdom? I want to implore you, beloved, let us fear the Lord in our lives. Let us acknowledge Him in all we say and do. He will direct our steps, and He will bring wisdom to our hearts and lives. God bless you. Here are my references. I'll see you soon with another informative video on this channel. God bless you.